Well, I think we'll get started. Welcome everyone to the AI in Medicine virtual series. Today we'll be joined by Dr. Chandi Chandrasena, who will be talking about administrative AI in practice, scribes, scheduling, and referrals. This series has been received in-kind support from all the Ontario Continuing Professional Development Offices, as well as foundational funding from Future Skills Canada. My name is Eric Wooltorton. I am the Interim Vice Dean of Continuing Professional Development at the University of Ottawa and a family physician as well. And here you see the Planning Committee disclosures that you can read and certainly go through. It's important to note that this program has several ways to mitigate potential bias. That begins with a needs assessment. The Planning Committee members are made up from people like you, from the healthcare community. No industry personnel are involved in the Planning Committee. The presenters are required to disclose any relationships at which we just looked at. And we definitely look for your feedback. Tell us if you have any information that you feel was biased that was being presented. And we'll talk about that in the evaluations at the end. This program is part of an initiative in continuing professional development. As you can see here, it's really important always to remember that this is information and opinion that's there to help you enhance your competence. However, it's not the official position of Queen's University or any of the other university offices of continuing professional development, and it doesn't necessarily set the standards for providing medical advice. This is important to remember. This content is to help inform you, to be thoughtful, and please use your own professional skill and judgment, as you always do, to assess the accuracy of the opinions and information expressed. There'll be a question and answer period at the end, and I'll be moderating that. Please submit your questions digitally and use the feature that's in the Zoom window below. We won't be using the raised hand through this, but you can definitely ask questions and we'll get to them as time allows. So, without any further ado, let me just quickly tell you about our speaker. Dr. Chandrasena is a family physician with over 20 years experience and Ontario MD's Chief Medical Officer. She provides clinical insight to inform digital health tools and drives initiatives in clinician engagement, change management, and education. She's a recognized leader in digital wellness. She's a key voice in discussions on electronic health record integration, data interoperability, and reducing technology-related burdens for clinicians. Thank you for doing that work. Dr. Chandrasena has spoken at numerous national and provincial conferences on digital health, AI, and the intersection of technology and clinician burnout. And she advocates for solutions that enhance workflow efficiency while preserving the joy of medical practice. So thank you very much. I'll stop sharing and turn this over to you.
Thank you. I'm just going to share my deck. So we're just going to make sure that we can see that, and then I will start. Perfect. Eric, can you see my slide deck? Is it there?
Yep.
Wonderful. Thank you
Good.
so much. And thank you, everyone. I'm really honored to be here today. So before I start, I'm actually in Ottawa. So I just want to do a quick land acknowledgement. So Ottawa is located on the traditional unceded and unsurrendered territory of the Anishinaabe Algonquin Nation. We extend our respect to all First Nations, Inuit, and Métis people for their valuable past and present contributions to this land. The Algonquin people have been the custodians and customary keepers of the Ottawa River watershed, Kishissippi, since the time of immemorial. I know the chat function has been turned off. This is usually where I ask where people are listening in from, but just it's a good time to reflect as to where we are. This is my speaker disclosure. I have no financial disclosures for this talk. I am Chief Medical Officer for Ontario MD, and I'm paid a salary for my work there. I've been involved in a number of AI projects and initiatives. I may tell you a little bit about the work we're doing, but also about our conference in October. I would love to do this talk without mentioning names of vendors, but it just wouldn't be practical or useful. So I just want to be clear that I'm not endorsing any of the vendors I mention. I haven't vetted any of them personally, and neither has OMD. So by the end of the talk, this is really about choosing tools, understanding the impact, and using them safely. So if you're thinking about AI, don't start with AI. Where you want to start is right here. Where is your day actually hard? AI only matters if it fixes a real workflow problem. So just because everyone's using it, just because it's a shiny new tool, just because someone tells you, oh, you need to use it, that's not where you want to start. Where you want to start is right here. What problem are we trying to solve? So, how do you figure out what problem you're trying to solve? So, a lot of you are probably thinking, oh, I know where my problems are. I can tell you right now the top five. But what I'd like you to do is start looking at it more from a workflow perspective, right? Because you're not actually going to know which technology is going to help you until you actually understand where that actual pain point is. So the easiest way to think about this is through your clinic flow. So that before visit, the pre-visit portion, the in-visit or during the visit with your patient, and then that post-visit, after-visit portion. But then there's also your admin team and your clinic, and then there's also the patients. Now, we traditionally talk about it in these three segments as if that's where healthcare ends. But really, we all know that it's not so nicely defined, but that's that's a good way of a framework of looking at where your problem is. So, what do I mean by mapping your current workflow or doing a 360? It's exactly that. I always say you get a large piece of craft paper because I'm from that generation where I loved craft paper and Sharpies, and you just draw it out. So, you can look at the whole workflow like this diagram here, or you could just pick a small portion of what you want to focus on. But what you have to do is you have to be really thorough. You have to list everything you do for that workflow. That's the only way you can really identify your pain points. Like, what do you do the day prior? What do you do the weekend prior? What do you do the morning before it happens? But you also have to map it from everyone's lens, not just yours, but also what is your staff doing? What's the front staff doing? What are the patients doing? So many of us have a hard time to actually pinpoint where the inefficiency is. We know where the problem is. We just don't know where the actual bottleneck, delay, what process can be automated. So finding that kind of piece, that problem is a very good place to start. So many of us think of technology as an EMR issue, right? And surprisingly, they think, okay, well, it's not working because we need better technology or we need more staff. That's kind of where we often go to. So when you think about your workflow and your problem, I want you to start thinking, where can I automate things? Where can I streamline things? Where can I change things? And could AI help? So I'm going to give you an example, not about AI, but just how to do it. So we had an issue in a clinic. Okay, let's be honest. I had this issue. I'm running late. I'm always running late. I like to talk. But when I went into the office, when I went to see the patient, sorry, into the clinic, the room where the patient is, my patient wasn't there. So I'm thinking, what the heck? I'm already running late. I'm already behind. And why isn't my patient in the room? Because it's now I'm going to get more and more behind. And I'm thinking it's clearly a staffing issue. We need to get people in the rooms or we need to hire more staff. Like, obviously, that's the problem. So at that time, my QI CPSO also came up. So what we did is we looked at that 360 of that patient journey from coming into the clinic to getting into the visit room, and we mapped it. We put it on a large craft paper in the kitchen, and everyone, post-its and everyone talked about their workflow. The front staff said what was happening there. The nurse said what was happening there when they were getting vitals and putting them in the room. And it was all mapped. And we had people actually watching and doing a little bit of surveys with the patients too. I'm not going to get into that because you don't actually have to do that. You just need to understand where it is. So what we found was that everyone was running late. So the evening staff was telling the patient to come at 9 o'clock for the appointment and to come 15 minutes earlier. But they wrote down 9 o'clock. The patient looked at when their appointment was, and they would often saunter in at 9:02. Then there's a long lineup on the front desk. And then by the time they called into the room, they were already 15 minutes late, and then the staff were behind. So instead of hiring new staff, what we found is we actually told patients to come at 8:45 to see the nurse, and we wrote that down. So the reminders always went out at 15 minutes earlier. So when they did come in, they weren't late. We put a self-check-in kiosk so that the people who could register themselves. And we made two lines, one for those coming into the clinic and one for those leaving outside of the clinic, so that they weren't competing with each other. And that actually solved the problem, but we wouldn't have been able to figure any of that out if everyone didn't actually put in the workflow, because quite frankly, we probably would have just hired someone or just assumed that someone wasn't doing their job, which is kind of like that first gut reaction. So I'm just gonna go to, okay, perfect. So before I jump into the workflow and the tools and kind of what we could use for those three kind of areas that I was talking about, I'm going to step back a bit and kind of say, okay, what AI is actually out there and what AI are we using in the community? So OMD just completed a clinician survey about AI use in Ontario. We had over 1,600 respondents, mainly physicians, also nurse practitioners, and also office managers and staff, but the bulk were family physicians, but also some specialist physicians in the community, just to understand what AI is actually being used and why aren't they using it? What are they worried about? And is it really as great as everyone thinks it is? And I'm going to pull in some of those results throughout my talk as we talk about actual vendors. What we did find out is that 60% of us have used an AI tool in our clinic at some point. And that's actually a lot higher than I expected. But it is spread over a number of different AIs, not just AI Scribe, but there's other ones that are being used. So based on that and what's available, what are people actually using in AI in practice today? So pre-visit, I always like to say this is about walking in prepared instead of scrambling. So there's a number of AI tools that are out there. I can't list them all because there's so many of them. There's a few that are physician developed. Dr. Byron Song and Dr. Hamyun Yan have created some of their own, and there's a few that are listed there. But AI chart summaries are basically a place where you can upload charts, PDFs, consult notes, and you get a summary of what's happening. And it pulls out those key issues and it tells you what the planned actions are. So this is really great if you haven't seen a patient in a long time, or if you have a brand new patient, or if your patient is very complex and they've seen many, many specialists and you're kind of like, okay, I just need to collate all of this and put them together. An AI chart summary could actually save you a lot of time. It's really important though that the summary or the tool that you pick actually references where the original notes are. So if they tell you, okay, here's my summary, there should be a link as to where they got that information and how they got it. There's also a piece of learning around it where you have to tailor prompts to your AI. So you would say, okay, give me all the information I want about back pain, right? You can kind of pick and choose, or you could say, summarize the last 3 visits and the outstanding actions, or I'm about to I'm triaging a referral. Can you tell me what the referring clinician has sent me? Can you summarize it all into a 2-page output so that I can quickly look at it? So there's a lot of places that you can use that. The other piece is about patient engagement AI. So a number of us use either maybe patient portals or patient secure messaging or Ocean to send forms out to patients before they come in. This is a way of doing it through AI. So it's an app. This one in particular is called First History, but there's a number of them that are being developed, which takes those questions. So if you know a patient is coming in for something, you can actually send them some forms or ask them questions where an AI, kind of basically a chatbot, would guide them through questionnaires. And then that information could be standardized. So you could send like a GAD-7 or a PHQ-9. And it's really about getting those answers before the visit itself. So it's really helpful to be prepared to get that complete visit. And when you're talking to your patient, it gives you a bit more than you had before. Now, this is so if we kind of go from pre-visit to in-visit, this is your during visit. This is probably where the biggest cognitive load is. And this is where AI helps the most for that. So AI Scribe, I think the majority of us know about AI Scribe. I'm not going to go into the details, but essentially it's taking your clinical encounter and it's documenting and structuring it into templates, notes, and consult notes. Now, there are a number of scribes that are out there. These are the top 4 as per our survey: Heidi, Tally, Scribery, and AutoScribe. And what it does is, like I said, it's that ambient real-time listening. Now, people think that they can just take an AI and start using it, which is true. You could, but you have to train your AI. You have to put a little bit of effort into it. Otherwise, you're going to find that long term, it's not going to do what you want it to do. And you're going to spend a lot of time actually fixing it. And then you might stop using it. And there's a lot of templates and there's a lot of notes that you could use. So you can have your AI Scribe do referrals. You can have your AI Scribe do patient summaries afterwards, and then it could send it to a patient through a portal. You can draft orders. You can draft summaries. There's a lot of things things. You could fill out forms. There's a lot of things you can do with your AI scribe, but you do have to put a little bit of investment in figuring out the templates and how you're going to use them. And also the prompts. The prompts are really important. So what you ask your AI scribe to do and the questions you ask, and I want it put into this template, they're important to be very specific, and that will actually give you the outputs that you would want. So it really frees out that cognitive load piece. So in the community, what's happening? Well, what we found out is that 58% of us have used or are using an AI scribe, which is a lot more than we think it is. Some clinicians save up to 1 to 2 hours per day. When we did a study in 2024, what we found that it decreased your documentation time from 7 to 90%, but you actually only saved 4 hours per week when you did it in an evidence-based kind of study manner. Now that actually correlates quite well with what we're seeing with other published studies that, we're not everyone is saving all that time. So some are saving 1 to 2 hours, but still the majority, it's about a 4-hour saving per week. But what happened is that cognitive load is a lot better. So a lot of us are not using AI scribes or stopped using it. And what the study showed, it's the editing burden. People were spending too much time correcting. There was a cost involved, the setup time, and they were worried about privacy. It wasn't necessarily integrated into their EMR. And 24% thought they were just fine. That's not where their problem was. And I think that's really important because it's not about getting 100% on AI scribe. It's understanding where your problem is and then finding an AI to fix it. And maybe documentation is not your problem. So the thing with AI Scribe also is, how do I choose, right? So there is a vendor record that Ontario has. Now, the requirements to get onto this vendor record were developed by clinicians. And it was quite robust, like clinical requirements, privacy and security and liability requirements. And that's really important because it was written from a lens of you and your community in your clinic and what you're liable for if something goes wrong, what happens to the data, who else gets access to the data, what about the recordings, all that was looked at. The contracts themselves were also vetted. So this is really important in the sense that if your AI scribe is on the VOR, but you're using it outside of the vendor record, you may not get the same contract. So you don't know if you're actually getting the same protections. And that's really important because those contracts were really carefully designed to protect clinicians. There's also a group purchasing power. The more people that use it, the lower the prices, and a number of new vendors have joined the list. So if you haven't looked at it, have a look at it and see, because it does provide some of the privacy security issues that people are talking about, and those are addressed there. So if we're kind of shifting from AI scribes to clinical decision tools, really, we've been using clinical decision tools all the time. We just didn't realize they were called CDS. I think I spent an entire week of meetings not understanding what an AI CDS was when people were talking about it. And then the aha moment when it's like, oh, you mean up to date, or you mean the guidelines that I read. And that's exactly it. So there's a number of AI CDS tools, which are open chats, like Up to Date has one. Open Evans that a lot of you may use has it. So when you start using a CDS tool, there's a couple of things you need to look about. Where do they pull the data from? Is it from respected sources? And do they show you what the source is? So there's transparency. So that's why these are so popular. It's low risk because, yeah, you can ask a question, it gives you a summary, pulls in the guidelines, but then it tells you exactly where they pull the data from. So you can still check it. There really isn't a black box to it. So now a number of AI scribes also have what I call AI Scribe Plus functionality. So they also have CDS functionality. So the three here and a number of others now have an evidence CDS type of piece so that you're now in your visit, you've got your diagnosis, you've got your AI scribe happening. Now, the AI scribe has recorded all that, put it into structured templates, but now there's a portion there where you could say, oh, hey, what is the guideline for otitis media now? Is it 5 days? Is it 7 days? Is it this antibiotic? Is it that antibiotic? And you can ask that question while the patient's there, and your AI scribe will send back and say, okay, you have to use it for X amount depending on age and whatnot. And that will all be referenced. So it actually acts as this tool where now you can ask it questions while you're there. Recently, I had a bone density and I was wondering, I just couldn't remember the fracs and the Carrick. And for some reason, I couldn't remember the cutoffs. So I put the bone density into my AI scribe along with the notes that I had done. And I said, can you just tell me what I need to do? And can you pull these guidelines? And it did. And it told me exactly what to do. And then it told me which medications to use. But it also showed the transparency of where it comes from. And so I knew that it was something I could trust. And it was just much faster than having to go through UpToDate and doing it the other way. So when we look at AI CDS, the other thing I do want to mention to you about AI CDS is I'm just talking about the chatbot here, but there are other forms of AI CDS. So there's the open evidence, UpToDate, kind of this, I have a question, give me an answer. Then there's the AI Scribe Plus type of CDS. I have a question. I've just had a patient encounter. I have all these other reports. I'm going to put it in, give me an answer. But then there's also a panel type of CDS, which is like, okay, give me your whole population of patients that one physician or nurse practitioner would have, but also give me what the clinic has. Now I'm going to run an AI through that, find everyone that has CHF or COPD and see if they're managed. And then I'm going to give you a list of all these patients that have not been properly managed that perhaps you want to bring in for assessments. That's called panel management CDS. I'm not talking about that today, but that's also another type of clinical decision tool. The other CDS that's out there is the nudge. So right now I'm pulling the information. I'm choosing to go and look for it, but there are AI CDS that while you're having conversations with patients would kind of tell you at the end, do you remember to do A, B, and C? Did you order this? Don't forget about this. So there's a number of ones out there. So you just have to figure out what you feel comfortable with. So who's using CDS in the community? Not a lot, because it's just kind of coming out, but about 18% are using it. More of them are using the open chat feature than the AI Scribe feature that I mentioned. So post-visit, this is where the day ends or keeps going. So it's really about how can I end my day when I'm supposed to end my day? So this is probably where the biggest opportunity is. And interestingly, where adoption is really still limited. So a lot of people are aware of these tools, but they're not using it. So for AI clinical admin, there's the draft patient summaries that you can send. That can happen with your AI Scribe. And, I would argue that the standard of practice should be that at the end of every clinical encounter that we're using an AI Scribe, we should be able to just print off a patient summary and send that to the patient either at the time of the encounter or shortly after in some manner. The reason I'm saying that is because there's a lot of AIs now that's targeted towards patients. There's an AI Scribe that's actually for patients, and patients don't have to tell us that they're using it, and patients are starting to do that because, as you know, many of them don't remember what we said and what's happened. So if we're going to still be in control a little bit about our AI and what happens, we should probably start looking at providing those patient summaries so patients don't have to go and get their own AI Scribe. So you're probably wondering, oh, well, that's great if patients have their own. Well, the issue is going to happen for liability because our AI Scribes are regulated. We know where the third-party data is. We know we correct it afterwards. We're responsible for that. The recordings are not kept. And we all know that a patient could have 50 things, but they're not all weighted the same. And that's where our clinical judgment comes in. But when you have an AI Scribe, there's no such thing as weighting or clinical judgment. They're all listed. So the concern comes, what happens if there's a liability? Which scribe, which recording now takes precedence? And that's something that's coming down the pipeline. There's also a number of AIs that summarize the results. Billing AIs. There's a number of billing AIs which are integrated into the scribe, which could help you with the billing because, as you know, for family physicians in particular, we're not billing for the work that we're actually doing. It's quite complicated. Sometimes I think you need like a PhD to understand family medicine billing. But also we can use AI for completing forms, writing the letters, writing the referrals. There's a number of them. There really isn't one or two that I can say, okay, here, this is the one to use, because it really depends on your workflow and the integration you have. If it's integrated into your EMR, it's always better, but not all of them are. And we don't always want to pick the ones that our EMR is using because that might not be the best one or meeting the needs that we want. So it's still early stages. The admin team part and kind of AI for everyone else, not just from a clinician perspective, is very, very important. And this is a part that we really don't talk enough about. So the AI tools are just not for you as a clinician. It's actually for your entire clinic, because if it benefits you and it benefits others, it actually benefits everyone. So AI for staff is quite interesting. So there's AI scheduling that's out there. Strello, Cortico, they tend to be used quite a bit for AI scheduling. But like I said, there's so many that are out there right now. AI inbox assistance is one that's actually come to the forefront. So Wave the Wait and Felix are the two largest for market share. But there's, again, Cortico is there, and there's a number of other ones. OMA had recently funded OMD to do an assessment of AI inbox assistance in terms of what's out there, what do clinics like and what they don't like. That's actually just completed, and we'll be publishing a report soon for those who are thinking of using an AI inbox assistant. But what I can tell you right now, kind of a bit of a spoiler alert, is that they're still very immature, and they're still learning. And so a lot of times what's promised that they can do isn't actually what's happening. It's very much linked to faxes. So it's not taking in labs or HRM reports or patient portal messages or other messages. It's very much around faxes and e-faxes. And you do have to put a little bit of investment of time and training to get it done. But the clinics that have done that have said they've saved so much time for their staff. And when staff have left, they actually did not have to hire new staff, which is something that is quite a value for clinics where we're paying for our own staff. So if we then kind of look at what are our concerns, right? Like overall, so like I kind of told you, there's all this AI out there. There's a number of places you can use it. So what are we worried about? And so when we looked at our survey, we actually looked at people or clinicians or survey respondents who said, I'm aware of the AI tool, I'm just not using it, which is very different as to why aren't you using it? Why aren't you aware? And what we found is depending on the tool, you had different reasons why people weren't using it. So for AI Scribe, they were talking about the editing burden, the cost, the setup time. AI Inbox is that they want system funding for this. The integration makes it a lot better. AI CDS, they weren't really sure if it was going to benefit because they had a really good workflow as it was. They didn't really have time. They worried about privacy concerns. And in general, what we found is people were like, it's time, privacy, and cost. And we hear that quite a bit. So the other thing that we heard from this survey is confidence. So you're more likely to adopt an AI or try one if you feel confident in understanding and evaluating it. And 42% did not feel that they were confident. Interestingly, if you were in a position in your clinic where you were the decision maker as to which AI you used or which EMR you used, you had more confidence about using it. So those individuals tend to use AI more than individuals who didn't have that decision-making capacity. The other thing that's also important to understand is that in the community, we can adopt things a lot easier than you can in organizations or hospitals. So that actually increases our confidence and understanding of AI because it's something that we want, and we want to see this tangible result right away and make it worth the money that we're paying. And that actually builds our confidence a bit more, which makes us more likely to pick and choose AI and more likely to ask the questions that we should be. In terms of challenges with AI, it's no surprise, legal and regulatory was the number one challenge, is the privacy, the data, the legal, the liability. The next challenge was over-reliance. If I start using AI all the time, how am I going to use it when I don't have it? What happens with the AI doesn't work? What happens if I'm like somewhere where there is no AI and I have to use my clinical skills again, and I'm really scared that I'm going to start getting reliant on it? Because you're going to, like, we are going to be reliant on it. Think of your GPS, like who can now navigate without their GPS? Misinformation was pretty high up there also, as in terms of, am I getting back that's accurate, but also misinformation that's going out to patients and what's out there in terms of AI in general, and how are we navigating that? And that loss of human touch, and then cost, obviously, and time, and then integration. So When we ask this question, who would you trust to verify an AI tool to make sure it's safe and effective? It was really interesting because the majority, 72% of the 1,665 that answered, provincial associations were who they trusted the most to verify their tools. Then it was the regulators like CPSO, then it was the national colleges, and then the national associations. Interestingly, colleagues and word of mouth, which I've always known, like honestly, I can't see any of your faces, but you're nodding. If I was the doc next to you and I told you how amazing it was, and I kind of told you, oh my God, it was a game changer, you're going to try it. So colleagues and word of mouth was actually pretty up there, more so than academic and research bodies, more so than government. And trusting your own evaluations was higher than vendors. I have to say, I was really happy to see vendors lower down because I kind of feel like there's a conflict of interest there. But this is kind of what we have to target if we want people to feel confident and safe in using AI. So what about the risks? Privacy, security, liability, data governance. So we've been seeing these exciting opportunities, right? There's so much AI out there. You're probably getting advertisements. You're coming to conference, you're seeing, and you're like, I want to try it. There's so much possibilities, but there's real challenges and risks, and you can't ignore that, right? And so the reality is our regulators, the system, we're still catching up. So when we did the AI scribe study in 2024, these are the areas that came out in terms of biggest concerns, and they still are. Patient consent, right? That's a really big thing. It's that clear communication and information to patients on what you're using and getting express consent from patients. So for AI scribes, now that we're using it, sure, having a poster in the waiting room and having your staff kind of give out a form that they're aware that it's happening, and then just kind of mentioning it before you start the recording to say, as you know, I'm using an AI scribe. That is fine. But now that we have AI CDS decision tools, the question becomes, do we tell patients that we're using that? If we're scanning charts, do we have to tell patients that we're using that? If we're starting to use other AI billing, probably not so much AI billing, but as we're using AIs, that patient consent piece becomes more and more relevant, that we need to really understand what is it that we have to do. The other is data use, right? I'm going to tell you again, there's no such thing as a free lunch. We've heard that with drug companies forever. It's the same thing with AI vendors. There is no free lunch. So if you're using a free AI, there is a way that they're making money off of it, and data is king. So you really have to look at those contracts. So even with a free AI, I would ask them, give me a written contract of what's happening to my data. Where is the liability? Where is it going? Are you selling it to a third-party vendor? There needs to be some accountability there. So just because it's free and it works for you doesn't mean you should use it without due diligence. And you can do due diligence on it. So I'm just asking you to please get that in writing. If you're a physician, the OMA will look at any contract that you have and kind of help you. If it's an AI scribe, I do urge you to look at the vendor of record and get your AI scribe through them, because all that due diligence has been done. In terms of algorithm training, there's a lot of issues around that because of bias. What LLMs are you using? And we all know that with drug research that's out there, there's a lot of bias. There's a lot of bias in terms of our social determinants of health, the population we use, where the studies were done. So that's no different for AI. But now you can actually pull in a lot more bias, and it could be augmented. So you do have to kind of look at AIs, and you should ask them, when you're using a clinical decision tool, how are you mitigating the bias? And there are AI tools that actually mitigate the bias. So you want to kind of say, what are you doing to make sure the data I'm getting is the most accurate, right? So there is a number of issues there that you want to think about. Liability is kind of the biggest thing, right? So in Ontario, and also for Canada, because of CMPA is more national, but in Ontario, these are our three main regulators and associations or organizations that we care the most about. What is the CMPA saying? What is the college saying? And what is the IPC, which is the Information Privacy Commissioner, saying? So I'm not going to go through all of this because then I'm going to be way over my time. But CMPA has a really good AI guidance. And if you're looking at using an AI tool, I would recommend reading it and really following what they're proposing, because that's what's going to protect you if there's a problem later on, and especially looking at those contracts. There's a checklist that the CMPA has, which is quite good. And it's really about asking those questions that I've been talking about right now. CPSO also has considerations for AI in practice, and they actually overlap quite a bit. So you're not learning anything new, but it is very good to look at. And as you notice, this is a screenshot of their webpage, but really they're talking about accountability, data privacy and protection, bias, transparency, and accuracy, which is really where the biggest concern is. And that should be outlined in all your contracts. So again, if you're using a free AI, you need to have a look at that contract and in writing as to what is happening and answers to these questions. And if your vendors can't give it to you, you may not want to take the free AI tool, because you are probably opening yourself up for issues in the future, because right now this is new. We haven't really had a big complaint from anyone in the community from using AI. So we're not really sure where it's going to play, but right now you want to protect yourself. IPC has just released their principles of responsible use of AI. So there's two things that they've released: a checklist for health sector before using AI, and just in general how to use AI. It's also a good place to look, because you'll hear from vendors, oh, we're HIPAA compliant, we're PHIPAA compliant, oh, we have ISO. Like, it's really understanding what you actually need for you to be safe when you use this with patients and their patient health information. Okay, so how do I choose? Like, it's kind of like, oh, okay, great, Chandi. You told me I'm going to have to spend all this time figuring out what my pain point is. And then here's all these tools that are out there. And then it's going to be like, okay, now you've told me I need to be scared, but I want to reframe all that if that's what you're thinking. What I'm telling you is that there is a clear way of figuring out how to choose things. And it's stuff that we do all the time with our patients. I'm just now asking you to extend that to your clinic. Right? When you see a patient, you figure out where the problem is. You don't jump to the treatment without identifying exactly where the issue is. Then you evaluate it, and then you figure out the problem, and then you do the treatment and the investigations, and then you decide. Same thing for your clinic, but now you're going to do it with a workflow piece. There's a number of tools that you can choose. You don't have to figure them out on your own. You can ask. There's a lot of places where you can get that information. And then finally, you just have to be aware of the privacy concerns and considerations. So it's stuff we always do. I'm just asking you to now apply it outside to your clinic as a whole. So how do we choose? The American Medical Association has this framework that I really like, because it really asks these three questions. So before you choose any digital tool, AI or anything, before you kind of say, this is what I want, these are the questions that I always ask myself, and all the questions that I kind of build into a lot of the talks that I do. First thing, they don't have to be in any order, but the first one is efficiency. Is this making my clinical efficiency better or worse? And when I say it's not just me, it's like the clinic, the team, the whole piece, the workflow. Is it helping? Because if it's not helping, stop using it, right? Stop looking for band-aids and say, okay, I've already invested all this time in this, so I'm just going to keep going. AI is not like our EMR. EMRs, we're kind of handcuffed to it, but in AI, we can just say, you know what? No, thanks. So is it working for clinical efficiency? Is it better or worse? Is it enhancing my professional satisfaction? I think this is really important, because this also builds on the quintuple aim, right? If it's making me better, if it's and when I say me, it's the clinician using it or the staff using it. If it's adding burden to me, do I really want to use it? Is it adding burden to someone else? Is it truly helping me? Am I like, oh my gosh, that was amazing? And really, if you don't get a professional satisfaction, if you don't get a hit of, oh, this is so cool, I just saved 10 minutes, then maybe that's not the tool for you either, right? And very importantly, is it improving patient care? Is it actually making it better for my patients? So if you look at something and you say, okay, is it improving efficiency? Well, it may not, if that's not your pain point. Is it bringing me a little bit of joy somewhere in this clinic or myself? Then yeah, that's great. If it's not, maybe you shouldn't be using it. And is it improving patient care? Because if it's not, if it's making it worse for your patients, please don't use it. But if it's actually improving it, then that's actually something that will help us overall. So start kind of looking at these questions when you're asking for anything. So then you're probably like, okay, but then how do I decide? Okay, well, we're all really good as clinicians to decide on a new drug, right? A new drug comes along, a drug rec comes in, and they say, look, we've got this great drug. Are you going to use it right away? Probably not. So what do? We look at the evidence. We look at the clinical trials. We look at the RCTs. We look at the real world studies. We look to see if it's industry funded. We have conflict of interest for our talks that we always give because it's important to us. We want to know if the people or that's telling us about it have some sort of conflict for it. Then we look at sample size and populations. Does it apply to my patients? For drugs, we use a lot of them off label. We are using it at our own risk. But it's less of a risk if it's a standard of care or if it's been evaluated properly. Then we look at outcomes. We look at efficacy and effectiveness of a drug. Did it really work? Is it going to work in my practice? Then we look at benefits of a drug, right? Survival rate, lab values, quality of life, whatever it is, we have metrics that we assess, okay, is this drug working or not? Right? And if it's not working, we increase the dose, we switch to something else, we go to another class. We have this natural framework of assessment already built into us. We always look at safety, short, long-term risks. What are the trade-offs for the benefit? Yeah, it's going to be worse here, but it's so good here. We're going to talk to our patients about it. We're going to decide. We look at black box warnings. We look at market surveillance. Then we think about the cost. Like, do we really need another drug that when we have 50 others and this one costs 3 times the amount and is so expensive? Is this the better one, right? Is it easy to use? If it's once a day, it's better than 3 times a day. We do this all the time. We do this all the time for every sort of medical treatment we have, every sort of drug, everything. So what I'm saying is start thinking of digital health tools the way you think about your drugs and your treatments. I always say that I think of digital health vendors as the new drug companies of the future, and that we should really start thinking about approaching it the same way. Would you let a digital health AI into your clinic without a contract, without understanding what's happening, without doing your due diligence, or even just asking these questions? So find the evidence. Who built it? Is it a big tech? Is it a startup? Is it clinician led? How many physicians or clinicians or NPs or even clinical staff do you have on your development team? Have a look at their webpage. Does it make sense? Who's in your leadership? Where's the proof? Did you do a peer-reviewed study? Have you done anything? Have you published anything? Or is this just kind of marketing claims, right? Have you really looked at physicians a pre and a post and in their clinics, and has it actually helped? Where's the proof? What's it trained on? What's your data you're using? What is your bias? Have you mitigated it? I always add in here, what's your environmental impact? Have you actually thought about AI and environmental impact, and have you put that into your tools somehow, and how are you mitigating that? And I also put in bias in there. And for me, personally, it's really important for me to see who is in the leadership of the company. And I often look to see if they have family doctors, because that's obviously my bias. And I often, to be honest, I also look to see if they have doctors that are not so tech savvy. So they actually have docs who are more clinical, who are part of the development, but who are not tech savvy, who aren't like your early adopters, because that means a lot more to me when I'm in my practice. I look at the outcomes. Does it actually work? Do you have stats that actually reduces a burden that's kind of somewhere along the way? Do you have physician champions that aren't paid by you to tell me that who could help me kind of navigate this, right? What's the patient impact, right? Is it helping diagnosis, treatment, admin tasks? What's the transparency, right? Can I see how the decisions are made, or is it this little black box and now you're giving it to me and I'm not entirely sure how you got to that answer? For safety, which is really important, bias and liability, like I was talking about, but the regulation and oversight. And like I said, OMA, if you're a physician, OMA will look at your contracts. But then there are things like the vendor of record that are there. There are other places that you can search to kind of say, okay, is this a good one that I can use? So the question is which AI tool should I use? Which vendor should I use? The question is, what's going to solve my problem? Here's the ones that say they can solve my problems. Now, how do I use my framework that's already ingrained in us to assess and decide which one I'm going to use? And then I'm going to start trying it small, and then I'm going to try it and see. Cost is a big one, right? Cost is huge, but not just money in terms of the cost, it's very important, but also the time savings. And does it add complexity? And okay, it might be cheaper for you, but now your staff has to do more because you're going to pay when your staff have to do that. Look at your contracts. Can you switch in and out very easily? And like I said, data, right? So where do we start? And that's really the biggest piece is like, okay, you've told me all this. Where do I start? Okay. So the biggest mistake actually is trying to adopt everything at once. So pick a pain point. Like I've always said, you pick one problem, one tool, and see if it actually helps. So one pain point. Is it inbox? Is it patient messaging? Is it documentation? If everything is a problem, nothing is going to change. So you have to pick one. When you pick that one pain point, you need to figure out what is your metric of success, right? How are you going to know if this is helpful or not? How long are you going to try it for? All that needs to be kind of itemized a little bit. When you pick that pain point and you try that tool, not 5 tools, one tool, you get someone in your office, you grab a colleague or a team member, or maybe it's you. We're going to do it small. It's going to be a small pilot. So for AI Inbox, it's going to be the front staff. But what you're going to do is you might pick initially one staff member to look at it and kind of look at it, and then one of the clinicians to work with that staff and a vendor to make sure it's being trained properly. And you need 6 months. So in 6 months, you're going to sit down and say, okay, was it worth it? How much time did I put into it? Am I getting what I wanted? Was it worth it? If it's not, you walk away. And you have to do that because a lot of us don't do that. We just try the tool, we think it's going to work, and then we're disappointed or it's not helping. But imagine if you picked the tool and then you said, I'm going to give it a 3-month trial. And in 3 months, a marker of success for me is getting home by an hour extra every day. And I'm not going to do charts at home because I've done it in the office. Great. So now you're going to do that and you're going to see if that works. And for docs, I can't speak for nurse practitioners who are here or the team members of a clinic, but for physicians, we can get CME for this. We can use this as our CPSO. There's a lot of other ways that we can actually use that time that we've invested. And essentially at the end of the day, if it doesn't save you time, break up with it. So before I totally stop talking, I just want to do a pitch. The topics are very practical. It's not just AI, it's about digital in general. There's one-on-ones, there's workshops where you can ask your questions about your EMRs, because quite frankly, we need to learn more about that. I am going to stop talking and I'm going to stop sharing. And I think I kind of gave you everything I know in 45 minutes.
That was wonderful. That was wonderful. Thank you very much for the 4th session. I just want to mention to everybody, we'll have some questions in a sec, but that please remember to complete your post-program survey. It's really important for us to get feedback on what you liked, what you didn't like, how we could improve. Completing the post-program survey is included in your learning hours for the session, and that's how we do not only quality improvement for these CPD offerings, but it's also how you generate your CPD certificate by attending, by completing that. A recording for the link will be shared and emailed to participants when it becomes available within about a week. And this is the final session, so we really appreciate you, Dr. Chandrasena, for making the time to present today, and for the audience, of course, for joining us. I know there's some questions starting to come in, but my first question is one on engaging your staff. And I really love how you talked about the pain points and just getting everybody to agree on a pain point in that 360. Do you find it's hard to get staff to sort of consider some of these AI tools for scheduling or other, like, it's one thing for us, but do you find they're buying into it?
So I think it depends on the person, right? And the clinic, just like it depends on which clinician. What I've found is that if you pick a pain point that the staff have, and then you come with solutions to that pain point, then there's more buy-ins. You're going to have resistant staff for sure, 100%. I'm not saying everyone's going to jump on board, but you might be lucky. And first of all, you might be lucky to have staff. A lot of clinics don't have a lot of staff, and I am acknowledging that. And I am also acknowledging that we're all remunerated in different ways. So, but this is something that can happen regardless of which type of clinic you're in. So if you have that buy-in and you've brought that in and you have someone, you know, staff vary, right? But there's always one staff member that's just a little bit more excited than the other ones, and they're just wanting to step up. That's who you engage. And you get them engaged and you get them to talk to the vendors and you get them to understand it. And then what happens is you get that buy-in, and that's the way to do it, hands down. Because if you decide, oh, I'm going to do a scheduling and I'm going to give it to my office manager, I'm going to tell my office manager, go learn about it, and now next month I want you to implement it, it's not going to work. You're going to get a lot of pushback and you're going to spend way more time. So you just have to kind of focus it from a different way. And Ontario MD, okay, my bias for Ontario MD. So Ontario MD is free of service for any community clinic, for physicians, nurse practitioners, and staff for any of the community clinics that are there. So you can reach out to us. I put the email in there, support@ontariomd.com. So if you're thinking of a tool and you want to get buy-in from a staff and you want to kind of work at it, our peer leader program can help you, because we can actually send you a staff to your staff, a physician to your physician, a nurse practitioner to your nurse practitioner, and an executive director office manager to your executive director office manager to help kind of work with you on that.
I also just want to say thank you for using language like, if it's not working for you, break up with it. It really gives this a personality. I know in our clinic we had about a dozen people start because the tool was being subsidized, and then that question of burden was really one that was coming up, editing burden, and even just people finding that the notes that they were reading from their colleagues were sometimes so inflated, or and we were concerned that sometimes there was some information that wasn't correct. So I like that idea of remembering that it's not just a tool to use just because it's hot and sexy and new. It's got to actually solve a problem. Do you find that you see people switching from one tool to another, or how are they? Is it sort of word of mouth? Like you say, they're getting information from a lot of places.
Yeah. And people do switch, right? And that's the beauty of AI, is that we're not handcuffed to it, right? So we can switch. I mean, as we get more into the integrated features, we start becoming a little handcuffed to it. But right now, people can switch. And it's really about picking one that you think will work for you, or you've had, like, you've spoken to someone who's in a similar clinic like yours and it's worked for them and they are similar to you, then try it. And then if it doesn't work, but like I said, you can't just try it without understanding it, because then in 3 months you're going to be like, this is awesome or this sucks. So what you have to do is actually understand what your metric of success is, and then know when to walk away. But I'm going to tell you, more and more physicians are actually walking away, I'm hearing, from AI Scribe. And I think part of that problem was that wasn't their problem to solve in the first place, right? Because they're like, you know what, my notes are better. I don't actually remember now the patient encounter because it's all done so nicely. The notes are much longer. I can't quickly scan anymore. I have to edit too much. So it really depends on what you're looking at.
Yeah, and it sounds like any relationship, just date for a while before you settle down.
Exactly. Yeah. Don't commit. Don't
Don't
commit
commit
until
long
you
term.
know. Yeah. And word of mouth is pretty impressive. Like, I have to tell you, I can publish all the studies until, like, I don't know, kingdom come. But if you have like a person that you trust, like, it's the same for like CHF, right? Like, there's all these guidelines, but I have a cardiology friend that I trust so much. And so, when I'm really kind of like, okay, I don't have time to read everything. I do read it because I don't want people to think I'm not reading it. I do read it. But when I'm like, I just need to kind of figure out what to do, I just call him up and I'm like, come on, can you just give me, like, what do you think? What's the pros? What's the cons? What do I need to worry about? What should I read? Because I can't read all of these guidelines. And he just condenses and says, these are my top 5 drugs, or these are my top 2. And then I go and look at it, and that's what I honestly end up using. But it's the same thing. Like, word of mouth is amazing, but you just have to be aware that you have to do your due diligence when it comes to the contracts, the consent, that's the part that really needs to be unpacked a bit more, and don't just trust people on that part.
And I also like what you said about the even things like the chart summary. Where did that information come from?
Yes.
Not just give me a summary. That's something I hadn't actually considered, which sounds like a really useful or interesting sort of future way of just re-encapsulating what's happened in a person's visit. Is that a common use that people are using now to just summarize those patients where you sometimes
Yeah.
they've had so many encounters that you could spend an hour reviewing their
Yeah.
chart, but
Yeah, it's starting to become, right. I think we all have a healthy dose of skepticism where you're like, okay, what if I miss something, right? If it's a new patient, what if there's a whole report that gets totally missed, and now I'm basing everything on, and this is going to cause a problem, right? So there's always those what ifs. So it's more like testing it out, right? Like, so test, like, don't go in and put like 500 pages in. Go in and do like 10 pages and then see what summary you get, and do a couple of trials and see if you trust it. And then just kind of make sure you can validate it until you know what's happening in there. But a lot of them, not a lot of them, but there are a few that don't tell you where the source is. And it's really important that they tell you where the source is, and you can click to the source and get your answer right away.
yeah, and that's ultimately the AI can't lose its license if it's leaving stuff out. We can.